Hello to everyone. My name is Maria Victoria Mateos from the University Hospital of Salamanca in Spain. And on behalf of all of my co-investigators of the MajesTEC-3 clinical study, I will present you the results of this phase 3 randomized clinical study conducted in relapsed refractory myeloma patients after 1 to 3 prior lines of therapy, in which Teclistamab plus Daratumumab has been compared with investigator choice of Daratumumab and dexamethasone with either pomalidomide or bortezomib. The background is that in spite of the fact that we have excellent options of therapy for our newly diagnosed myeloma patients, majority of these patients finally relapse, and we need very effective combinations as part of the first relapse and subsequent relapses. And until now, we basically use PI, IMiDs, and sometimes anti-CD38 monoclonal antibodies as part of the first line of therapy. So the unmet need will be the possibility for using immunotherapy combinations available to be used in every hospital for many patients. This is the rationale for this combination, a synergistic immunotherapy combination based on Teclistamab, BCMA-CD3 monoclonal antibody that Teclistamab is going to redirect the T lymphocytes into the tumor niche in order to destroy myeloma cells, but this activity is going to be enhanced by the use of Daratumumab, anti-CD38 monoclonal antibody. The study design was basically based on 587 relapsed refractory myeloma patients after 1 to 3 prior lines of therapy, randomized 1-to-1 to receive Tec-Dara versus Daratumumab plus dexamethasone with either pomalidomide or bortezomib. It's important to know that the sub-Q dosing aligned with the Dara schedule, and this means that this combination is given once per month after 6 cycles. And also it's important to note, and especially for the patients, that this combination includes dexamethasone, but only during the cycle 1, day 2, and day 4, before the 2 step-up doses, and this is an steroid-free regime from cycle 1, day 8. The baseline characteristics of the patients is reflective of patients that we see in the real-world practice, basically relapsed refractory after a median of 2 prior lines of therapy, all patients exposed to proteasome inhibitor, all patients exposed to lenalidomide, and more than 80% of the patients were refractory to lenalidomide, and 5% of the patients were previously exposed to anti-CD38 monoclonal antibodies. In terms of patient disposition and exposure, just to note how, as data cut off on August 1st, 2025, majority of the patients in Tec-Dara arm are still on treatment, 71% versus 28% in the control arm. But maybe this is the most important slide, representing the primary endpoint, progression-free survival. And it is possible to see how Tec-Dara significantly improved the progression-free survival with a hazard ratio of 0.17 and with a plateau phase from month 6, explaining how 83.4% of the patients remain alive and progression-free at 3 years in Tec-Dara arm versus 29.7% in the control arm. And this benefit indeed is sustained across the different subgroup of patients. This benefit is also observed in the overall response rate, 89%, but 82% of the patients in Tec-Dara achieved at least a complete response. And majority of these patients, 60% were in minimal residual disease negative in the intent to treat patient population, and almost 90% in the evaluable population, with not a huge differences in the MRD negativity rate between sensitivity 10 to the minus 5 and 10 to the minus 6, enhancing that Tec-Dara induced very deep responses. This combination resulted also into a significant benefit in overall survival, with 83% of the patients alive at 3 years in Tec-Dara versus 65% in the control arm. superiority sustained also across the different subgroup of patients. In terms of safety profile, if we focus on Tec-Dara, we have to consider cytokine release syndrome present in 60% of the patients, but in majority of the patients grade 1, 16 grade 2, and no grade 3-4 CRS event, and all patients resolved. ICANS was present in only 1.1% of the patients and all resolved. Neutropenia is a quite frequent hematological adverse event present in both arms. And infections are maybe the most relevant and the most frequent non-hematological adverse event. And grade 3-4 infections were reported in Tec-Dara in 54% of the patients and 43.4% in the control arm, so no huge differences. The most frequent infections were COVID-19 as well as upper respiratory tract infections. Important to note that Tec-Dara, Tec-3 started the recruitment during the COVID-19 pandemic, and when we had not specific treatment guidelines for the management of bispecific monoclonal antibodies, and majority of the patients presented hypogammaglobulinemia. The result of this situation was that 13 patients died because of infection with Tec-Dara, but 12 out of these 13 deaths occurred within the first 6 months of treatment. Once this was realized, the protocol was amended and all patients received adequate prophylaxis as well as support with immunoglobulins. And once this amendment was implemented in all patients, only one additional patient died because of infection beyond the first 6 months. This is something that you can see here in this slide. Infections decline over time. Quality of life evaluated throughout this questionnaire was also significantly better for Tec-Dara versus the control arm. And in conclusion, I would say that this synergistic immunotherapy combination of Teclistamab plus Daratumumab versus Dara-PD or Dara-VD in relapsed refractory myeloma patients after 1 to 3 prior lines of therapy resulted in the greatest PFS treatment effect to date with a hazard ratio of 0.17, with benefit in overall survival, with a higher overall response rate, complete response rate, and minimal residual disease negativity rate. Grade 3-4 infections were highest in the first 6 months, but as I previously explained, manageable with adequate prophylaxis. And another important information, the combination of Teclistamab plus Daratumumab is going to be broadly available, and it will be a new potential standard of care for relapsed refractory myeloma patients after at least 1 prior line of therapy, with broad potential across academic as well as community settings. And I stop here. Thank you very much for your attention.